One of the evolving areas of the treatment of advanced ovarian cancer is maintenance therapy. So we have 3 PARP inhibitors, olaparib, rucaparib, and niraparib, in maintenance all-comers, second and beyond line therapy, if a patient has a complete or partial response to platinum. All-comers, second line, oral, niraparib, rucaparib, and olaparib. Now, we have frontline maintenance, PARP inhibitor, olaparib, but only in BRCA patients. And then we have frontline maintenance, bevacizumab, with chemotherapy, again, up to 15 months. The point is we have 5 maintenance targeted therapies, 3 PARP inhibitors in second line, 1 PARP inhibitor in front line, and bevacizumab. Maintenance is here to stay, and the reason it's here to stay is for 3 reasons. 1, it works. All those studies show important, statistically significant, and clinically important delays in progression-free survival. And 2, they're relatively well tolerated. And 3, it's convenient. So that's the nuance of maintenance targeted therapy in ovarian cancer. It works, it's tolerable, and it's convenient. The use of targeted therapies in newly diagnosed advanced ovarian cancer has to be understood in the context of side effects. All anti-cancer therapies have toxicities. So let's talk about the 2 categories, anti-angiogenics, bevacizumab, and PARP inhibitors, in this case olaparib, for BRCA-mutated patients. So the most common adverse event associated with bevacizumab is hypertension. Certainly they can have proteinuria and other side effects, and we worry about GI perforation. GI perforations can be mitigated and reduced if you start the 2nd or even the 3rd cycle, and if you avoid treatment or the use of bevacizumab in patients that have inflammatory bowel disease. The side effect profile of olaparib and other PARP inhibitors is threefold. Fatigue, and that can be managed with dose delays and dose reductions. 2, bone marrow suppression, sometimes even anemia and thrombocytopenia. And 3, GI toxicities, particularly nausea, vomiting, and diarrhea, again, that can be managed with supportive care, dose delays, and dose reductions. So we have to have a healthy respect for these targeted therapies, but with dose reductions, dose delays, supportive care, managing the hypertension, if you will, in bevacizumab, managing the nausea and fatigue and bone marrow suppression with PARP inhibitors, these medications can be used with patients without a decrement in quality of life. All of these studies have had questionnaires, patient-reported outcome assessments, and there was no decrement. There's a lot of discussion about contraindications to bevacizumab. Now, the easy ones are non-healing wounds, right? Deep venous thrombosis that is not well controlled. Patients that have stable DVTs are eligible for bevacizumab treatment, but also in our particular patient, hypertension, because the most common serious adverse event is hypertension. So what we do is we certainly only start it if the hypertension is well controlled, and we ask the patient to monitor her blood pressure at home. And ultimately, if she starts to have elevated blood pressure, hypertension, if you will, then we manage it. And it can be managed without altering the dosing regimen frequently.